Welcome to the i3 Health podcast, where we explore the latest advances in medical research and treatment. I am Katie Cook from i3 Health. While small cell lung cancer is usually treated with systematic therapy with or without radiotherapy, survival rates remain low. Remaining up to date with the latest clinical data in systematic therapy and radiotherapy is crucial. This episode of the i3 Health podcast will focus on optimizing treatment selection, sequencing, and tolerability in small cell lung cancer. It features perspectives from two noted experts in the field, Dr. Chiang, Associate Professor of Medicine and Chief Network Officer at Yale School of Medicine, Smilo Cancer Network, and Dr. Henry Park, Associate Professor of Therapeutic Radiology and Chief of Thoracic Radiotherapy at Yale School of Medicine, Smilo Cancer Network. This activity is supported by an independent educational grant from G1 Therapeutics. Free CME and NCPD credit are available for this podcast. To claim credit and obtain further information, including faculty disclosures, visit i3health.com/ODA-SCLC-treatment.
Hi, welcome today. We're excited to be here. My name is Ann Chiang. I'm an associate professor of medical oncology at Yale Cancer Center.
Hi there, I'm Henry Park. I'm a radiation oncologist and associate professor. I'm also at Yale School of Medicine.
Great. And we're going to be talking about how to optimize treatment selection, sequencing, and tolerability in small cell lung cancer. Here are disclosures. These are the learning objectives to assess patient tumor and treatment-related factors, to personalize management plans in small cell. We're going to go over recent clinical trial data on safety and efficacy of novel therapies and look at strategies to enhance your patient's treatments with small cell. So we're going to start with this question: what is our current understanding of the tumor microenvironment and its significance for prognostications, treatment strategies? This is a really super exciting time in small cell where we are actually starting to think of small cell as being not just a homogeneous disease that you treat just with one platinum doublet anymore, but actually as subtypes with respect to molecular profiling, where you could start to think about targeting therapeutic vulnerabilities for small cell patients with subtype A versus subtype B, C, and D. And this has been extremely successful for non-small cell lung cancer with EGFR and other driver mutations tailoring therapy. So we're excited. This is what we're going to talk a little bit about today, the changes in our understanding of biology. This is a great paper from Charlie Rudin that summarizes a lot of work that starts to break down small cell as different subtypes, in this case characterized by the overexpression of certain transcriptional activators. So a subtype A having upregulation of a KEAT/SCUT-like one protein, subtype N having overexpression of NeuroD1 transcriptional activator, subtype P, POU2F3. And right now, what was really exciting as an extension of this work, just descriptive work, is sort of looking at the Empower 133 trial that has platinum doublet plus atezo, which I'll go over later in this program. But I think that the idea here is that if you break down these patients in terms of which subtype they belong to, the I subtype actually did better survival-wise with the addition of atezo, as opposed to in the placebo arm, you didn't see this benefit. So again, this idea that we may be able to develop better markers to understand prognostically which patients are going to respond to immunotherapy versus another therapy. That's really, I think, a big advance forward for small cell lung cancer. The next slide just shows you that we need this information because PD-L1, which is our main marker, one of our main markers for treatment decisions in non-small cell, does not perform the same way in small cell. And this is just an example of, in the literature, of a tissue microarray of 94 tumors that showed 0% PD-L1 expression. And so we've looked at PD-L1 expression in a couple of different ways. if you look at this Keynote 028 trial that had small cell patients treated with Pembro, the investigators actually changed, they didn't use TPS score, the tumor expression or tumor proportion score, but changed it to using a combined CPS score that adds the PD-L1 positive cells, including tumor cells, lymphocytes, and macrophages, to the total number of cells. And using this slightly different CPS scoring, they were able to see that 40% of the patients were PD-L1 positive, and this predicted for higher response. So maybe utilizing the PD-L1 staining and looking at the other cells in the microenvironment. But again, it doesn't perform the same way in small cell as it does in non-small cell. And the Checkmate 032 trial, where patients with small cell received Nivo or Nivo-Ipi, overall, there were about only 20% positive patients, and in the PD-L1 negative patients, you still saw responses. So again, PD-L1 as a marker is not the same as in non-small cell, and we need better biomarkers for small cell. So, some of this is work looking at the tumor microenvironment. This just shows you a paper that looks at FOXP3 cells. These are T regulatory cells. And perhaps we have to really look at other aspects of the tumor microenvironment. Here, Dr. Schalper, who does really great work in immunofluorescence, and we can start to look in the tumor microenvironment, not only at the number of cells that are positive, but also cell density and cell percentage. And this may help us to understand better how PD-L1 works in small cell. And this is just a quick schema of an investigator-initiated trial that Dr. Schalper and I have initiated. And this is just to show you that we actually looked at patients getting Ipi-Nivo that had relapsed disease. We did a biopsy pre-treatment and then on treatment at week 4, and we're looking at the microenvironment to see what predicts response. I think the most important piece of this so far is that we've been able to be very successful with about 2/3 of our patients getting these paired biopsies, and I think that allows us to study the microenvironment and ultimately learn more about this disease. So now I'm going to turn it over to my colleague, Dr. Park, to talk about the really important role of radiation in small cell lung cancer.
Thank you very much, Dr. Chiang. We're interested in seeing what the what the uses of radiation are in the limited stage and extensive stage space. So for limited stage disease, the overall standard of care is concurrent chemotherapy with radiotherapy. So the chemotherapy being platinum doublet, and radiation therapy either being 45 gray and 1.5 gray BID fractions, or somewhere between 60 and 70 gray, having 2 gray fractions once a day. There are also some clinical trials ongoing as well. These two have just completed right now. One is looking at immunotherapy in the concurrent setting, and one is also looking at immunotherapy in the consolidative setting after the chemo and radiation is complete. So once chemo and radiation is complete, then we also have the question of prophylactic cranial irradiation to 25 gray in 10 fractions. Once you get restaging scans that show at least a partial response. For limited stage disease, this is still considered the standard of care. However, there is a clinical trial that's ongoing right now, the SWOG S1827 study, or that's also known as MAVERICK, that's looking at MRI surveillance with or without PCI in this population. Also being studied is if you do PCI, if you can actually spare the hippocampus as well versus doing conventional PCI. But this actually requires an IMRT technique, or intensity modulated radiation, to really try to minimize the dose to the hippocampus and spare neurocognitive side effects as much as possible. This trial has completed, the NRG CC003 trial has been completed, and we're awaiting results for that. For the rare early stage patient, so if there's a patient with a T1 or T2 small cell lung cancer who's had a negative mediastinoscopy, the question is whether to consider surgery up front, and there is some evidence to suggest that this may be a reasonable option as well. We could do surgery, or for medically inoperable patients using SBRT and following this up with chemotherapy afterwards. This choice of local therapy, that often depends on the patient's ability to undergo surgery, and also the likelihood of rapid recovery enough to start chemotherapy soon afterwards, as well as the availability of the surgical and radiation treatment that can be done in a quick fashion, so that they can get on the systemic therapy. For extensive stage small cell lung cancer, the management typically now is concurrent chemotherapy with immunotherapy, even for those with small asymptomatic brain metastases. The platinum doublet, it's often accompanied by having immunotherapy with atezolizumab or also durvalumab. So there are two trials that Dr. Chiang will review a little bit more in the following slides. For prophylactic cranial radiation, to the same dose, this is still an option, although this is not necessarily as standard of an option anymore. There have been two trials now that have looked at this question that conflict, and I'll talk about that in one of the next slides. The SWOG study is open for this population as well, as was the hippocampal avoidance PCI trial. And then for the consolidated thoracic radiation question, whether or not you do radiation afterwards, if you get a complete response, or at least a thoracic partial response, using radiation therapy to 30 to 45 gray and 10 to 15 daily fractions is also something that is being investigated further, but has been standard previously. And then whole brain radiation, if you develop brain metastases that are symptomatic or progressive, can be considered, although there is more investigation looking at stereotactic radiosurgery as well for a limited number of brain metastases. So the next question is, to talk a little bit more about, the fact that there are conflicting dosing and scheduling strategies for radiation, and how do we determine the most appropriate regimen for our patients. So for limited stage disease, the INT0099 Torecity trial did look at 45 gray and 1.5 gray BID fractions, which became standard of care when compared to 45 gray and 25 daily fractions. However, the daily regimen was considered to be subtherapeutic, and therefore there have been two clinical trials since then that have looked at comparing this BID regimen to a higher dose daily regimen, the one that we use for non-small cell lung cancer very frequently. So 66 gray or 70 gray for each of these two trials, the CONVERT and the CLGB study. Both of them found that the daily fractionation was not superior to the BID outcomes, but at the same time, they appeared fairly close in terms of their survival curves. So in the real world, how do we handle this? I typically offer both the BID option and the daily option, and most radiation oncologists I know do the same. Some may have slight preferences of one over the other, but I tend to leave it more up to the patient, and also to determine which patients may actually benefit from one or the other. We often think about the patient's ability to travel twice a day for radiation. It's not something where you can just do radiation back to back. You have to wait 6 hours in between each of the doses. So they have to come once in the morning and again once in the afternoon, and really commit to doing a 3-week course, which for some patients is very convenient to get everything done in only 3 weeks. But each day really cannot be missed, and you really have to do twice a day each day. So even if a patient says they can do BID, you really have to be able to be sure that they have the resources that would allow them to do that consistently. If not, the other concern is whether or not it takes the patients have to be away for a long time, or if they rather get the treatment done very quickly, or if they're okay with it being prolonged over 6 to 6.5 weeks. There's also there was not much of a difference in acute toxicity overall between the high dose daily fractionation and the BID fractionation. However, the overall acute esophagitis may be slightly higher for those who are getting BIDs. So for those who you think can tolerate that better, that may be a good option as well. But the practice patterns vary throughout centers in terms of how often they use the BID or the daily fractionation. A lot of it depends on the patient population and also how close they live to the facility, and how easy it is to get there. So there's various factors that may account for that. For extensive stage small cell lung cancer, if we know the Yermix study here used consolidated radiation and with actually a very high dose BID fractionation. This has been really replaced by a much lower dose from the CREST study here, from the Slotman study in 2015, that used a much lower dose here, 30 gray and 10 fractions, only requiring 2 weeks of treatment. The Empower 133 and Caspian studies, as Dr. Chiang will allude to later, did not allow for consolidated radiation with maintenance immunotherapy. Looking at retrospective data, this does appear safe to do, but at the same time, there's not we don't have any randomized evidence yet suggesting that this is necessarily the approach that we have to take right now for all patients. So in the real world, if you're not on trial, we do consider consolidated thoracic radiation for certain patients, depending on the disease burden and also patient performance status and preference. So the patients that we tend to do this most on are those who have limited disease overall, especially the part that makes them extensive stage. So the metastases, if it's overall not too burdensome of the disease, and they're able to also respond well to the initial chemo and immunotherapy, then we tend to consider consolidated thoracic radiation. Depends on our field size and the patient's tolerance, how well they've gone through the chemo and immunotherapy in terms of their side effects as well. So this is all taken into account. We typically don't escalate up to 45 gray in 15 fractions unless we have a very specific selected patient who wants to be very aggressive and where we feel like the field is small and their extrathoracic disease is quite minimal. But we do have a trial open as well called the Raptor study, or NRG LU007, that is investigating this Empower 133 regimen, plus minus the consolidated radiation therapy, not just to the thorax necessarily, but even up to 5 metastatic sites overall. And then finally, for me, when do you consider prophylactic cranial irradiation for your patients? So in the limited stage setting, the Operin meta-analysis here showed an overall survival benefit to prophylactic cranial irradiation. We know that from that 25 gray and 10 fractions is superior to a higher dose, which is why we use that dosing. However, all these clinical trials were done in the pre-MRI era, when MRIs were not routinely done for screening purposes or for surveillance purposes. So there may be treatment for micrometastatic disease that was not caught on CT scans, but on current MRI scans may be caught and therefore given. Perhaps we were actually giving treatment to patients who we thought we were prophylaxing. So in the real world now, what do we do? In general, for limited stage, we tend to lean towards PCI still, given that this has been a standard and has not yet really been overturned as a standard for 25 gray and 10 fractions. The choice of PCI is based on many factors, though. And a lot of patients, really don't necessarily want to do this for good reason because of the potential cognitive and functional deficits that they may have. That's because of the radiation. However, at the same time, we do know that the only level 1 data we have so far does show a survival benefit. But you have to also account for patient age and their baseline status to see if this would really impact their quality of life so much that would be unacceptable to them and potentially not worth the potential improved survival, and their preferences for avoiding potential toxicities versus avoiding brain metastases. I think a lot of these patients, I do offer hippocampal avoidance based on the PRIMER study that was published in JCO 2021. There have been some conflicting studies from this in Europe, and we're awaiting our main US study, which has completed accrual, the NRG CC003 study, looking at whether or not prophylactic cranial irradiation with hippocampal avoidance will be helpful for neurocognitive outcomes without a detriment to survival. And then the ongoing trial we have currently is the Maverick study as well for this population. This will hopefully answer the question in the more modern age of MRI. For extensive stage small cell lung cancer, there's conflicting data. The EORTC study by Slotman did show an overall survival benefit to PCI in the pre-MRI era. The Japanese study recently from Takahashi did not show a survival benefit to PCI in the MRI era. So the more modern study not showing a benefit has led us off trial to generally lean away from PCI, although we do respect patient preference regarding minimizing intracranial recurrence, which we do know that PCI certainly would do that. We also know that patients who can't get MRIs or do not want to get MRIs, either for surveillance or upfront, would also be patients that we should be doing PCI on, even in the extensive stage setting. In the setting of where they can get MRIs, then ideally we would enroll in the Maverick study. If patients do develop brain metastases, there is a choice of stereotactic radiosurgery for patients with limited disease. We typically limit this to those with 1 or 2 lesions that are small and have overall demonstrated a good natural history. But this may be based on intracranial and extracranial disease burden, preferences for delaying potential toxicities of whole brain radiation versus avoiding brain metastases. Because what we don't want to do is, if possible, is to give stereotactic radiosurgery and then the next scan they develop many more mets that we would have to give whole brain radiation afterwards anyway. So this is something that we consider strongly, but there's ongoing studies on this as well.
Great, thanks, Henry. I think for medical oncologists, it's really great to hear that directly from the radiation oncologists and how that informs our practice. Now we're going to turn to therapies with atezo and durvalumab. in the first line for treatment of extensive stage, and try to address some of the questions of how do you select these patients for these therapy and what their efficacy and safety data are. So I'm going to start with a case study. This is a patient of mine, 75-year-old African-American female, 45-pack-year tobacco history, presented with 20-pound weight loss, a worsening shortness of breath on exertion and cough, some prior medical history, coronary artery disease, vascular disease, diabetes, hypothyroid, and her physical exam with shoddy neck lymphadenopathy, right axillary lymphadenopathy, and the PET scan confirms, and you can see that image on the right, 6.2 right lower lobe mass. It's inseparable from the pleura. There's additional nodules in the right lower lobe, and there's lots of bulky lymphadenopathy in the hilar mediastinal, and then that right axillary region. The brain MRI is negative, and the biopsy of the lymph node shows small cell carcinoma, positive for synaptophysin, and this is an actively proliferating tumor with Ki-67 of 90%. How would you treat this patient? So I've got a couple of options here. What regimen do you use? Carboetopicide, carboetopicide atezo, carboetope durva, cis-etope durva, and actually the answer is pretty much all of these actually. The first one is not, I included there because many of these patients, as you know, are very sick and they'll end up in the hospital, and they do benefit from inpatient treatment. And then typically I'll add on the immunotherapy on cycle 2, for example, as an outpatient. There is a way that you can get reimbursement for giving IO inpatient, but we have not been able to do that yet. So now I'm going to go into the data for the first line therapy, the addition of immunotherapy to our platinum doublet. And this is exciting because this was the first 2 FDA approvals in a long time for small cell. The first one is the Empower 133 trial, which I talked about before. And this was atezo plus carboetopicide versus placebo plus the platinum doublet, followed by maintenance atezo or placebo. And this was to patients treated until progression with the overall endpoints of OS and PFS. And this is first line for patients with PS 0 to 1 and treated asymptomatic brain mets were eligible. So here's the Kaplan-Meier curve. This is updated at 2 years. You could see the 18-month survival, 34 versus 21 in the atezo arm, and the median overall survival, 12.3 versus 10 months. And this was approved by the FDA on the basis of this trial. Here you can just see that if you look at TMB, which we thought might be a biomarker, doesn't matter depending on which cut point you use, 10 or 16. Still doesn't really work as a good marker for atezo benefit. The Caspian trial was a similar trial where patients were randomized to durva plus platinum doublet, followed by maintenance durva tremi, plus the platinum doublet versus followed by maintenance durva. Tremelimumab is a anti-CTLA-4 antibody, and then this is the control arm of platinum doublet. Now, should note that you could use either cis or carboplatin in this trial. The Empower 133 was just carbo. There was optional PCI noted, the primary endpoints of OS, and in this trial, you could have asymptomatic, untreated brain mets that were permitted. For this trial, the durva tremi arm did not show a benefit, so I'm not going to show you those curves, but I'm really going to concentrate on the durva plus EP arm. Here is the 3-year overall update here, and you can see that the Kaplan-Meier curve shows at 3 years 17.6 benefit versus a 6% benefit, so almost threefold improvement in overall survival at that endpoint. Very similar median overall survival to the Empower 133, that's 12.9 versus 10.5. So on the basis of this trial, the FDA granted approval to durvalumab plus EP for first-line treatment. This is a 3-year update. Here's a table I put together that just puts this side by side. You can see, again, the median overall survival is very similar. The hazard ratio is very similar. The 2-year overall survival, almost identical. We do have that 3-year overall survival for the Caspian. The Empower 133 treated brain mets only. At Caspian allowed asymptomatic brain mets and allowed cisplatin as well. I think these are two very consistent trials. I've used both of these drugs. They're tolerated very well, and I'm going to show that to you in the subsequent slides. So I'm now going to turn to how to follow patients and assess treatment response. Now this is my patient. She has an excellent response to 4 cycles of carbo, etoposide, and atezo, and she continued on maintenance monthly atezo, and then up to cycle 9 of maintenance atezo, so doing really well. The restaging scans every 3 cycles or 3 months showing stable disease, and she tolerated this drug very well, except for IO-induced lichenoid rash, but that was controlled very easily with steroid topical cream. So again, here you can see that she has probably a little scar tissue here, but certainly that a nice shrinkage of that initial right lower lobe mass. And the question is, how long do you continue the maintenance immunotherapy? In the trial, in Empower 133, as I mentioned before, it was continued until progression of disease or side effects that required stopping drug. Here you can see the treatment-related adverse events between the atezo or the placebo arm, pretty much identical. The duration of the maintenance atezo was 4.7 months in the atezo arm. The placebo continued for about 4.1 months. And the average total cumulative atezo dose was 7 doses or 8,400 milligrams. So really pretty well tolerated. Here, the immune-related adverse events, and these are ones that we're familiar with as oncologists now, and grades 3-4, really pretty minimal, 0.5 to 2% in grades 3-4 in the atezo arm. And it always cracks me up to see the immune-related events in the placebo arm, but also very low. Here are the serious adverse events at the 3-year update. And again, very similar between both arms. So very well tolerated. This is for durvalumab now, the Caspian trial. And again, pretty much what we expect here, pneumonitis, hepatitis, diarrhea, colitis, all really in the 1 to 2% range. So both of these regimens really well tolerated. Which immune-mediated adverse events concern you the most, and how do you monitor and manage these? Well, we're getting very good at managing these. So my patient developed acute shortness of breath and dry cough for several days. She was evaluated in the ER. She had some hypoxia, but she was stable hemodynamically. And the CTA here showed no PE, but bilateral ground glass opacities. So how do you manage this immune toxicity, and do you consider re-challenge with IO? That's a common question that I have. There's a lot of groups that have developed algorithms for management of immune-related adverse events. In general, if they're grade 1 and asymptomatic, you can continue the immunotherapy with close monitoring. If they're grade 2, mild to moderate symptoms, I usually hold the treatment and provide supportive care. And depending on the symptoms and the patient, I may initiate oral steroids here. Every time you initiate the steroids, it's important to remember that you're going to taper those steroids over a long period of time. Usually they've bought themselves a 4 to 6 week steroid taper to reduce the recurrence of symptoms. And sometimes I'll go decrease 10 milligrams of prednisone per week. But if their symptoms get worse, I might switch that to 5 coming down. And then you can consider reinitiation of immunotherapy when grade 1 or less, or you can just watch them. And many of my patients, I just switch to monitoring. If they're grade 3 to 4, then the advisance is to discontinue immunotherapy, and there are lots of organ-specific algorithms out there, and initiate high-dose steroids promptly, either prednisone or IV, depending if they're outpatient or inpatient and how sick they are. Again, they bought themselves a long steroid taper, and can consider reinitiation with caution. Typically for grade 3, 4, I don't, and I just watch them, because many of my patients who've developed these immune-related adverse events actually do quite well with just surveillance monitoring. Grade 4, I would warrant permanent discontinuation, and if it's important to realize if they have no improvement or progression in the first 2 to 3 days, then you can add an additional immunosuppressant, for example, infliximab. And actually, there are a number of there's a lot of research going on in this area that are additional immunosuppressive drugs that can be utilized. And this is just to show you, if there's an article in the literature that did show that if you had an immune adverse event of any grade, it actually improved your progression-free survival and overall survival in this particular paper. So that I do tell my patients if they're anxious about not being on therapy. And this is the spectrum of immune-related adverse events, and basically any organ in your body can be subject to these toxicities. And I've had actually patients develop almost every single one of, or certainly adverse events in every one of these organs. They all can be treated with the steroids, as I mentioned before. This just to show, this is a paper that shows you that you can have onset of immune-related adverse events really anywhere in the course. It can be, the median onset is 5 to 12 weeks after initiation, but it could be within days of the first dose, or it could be after months of treatment, and it can also be after discontinuation of therapy. So really important to have that at top of mind whenever your patient presents with side effects or with symptoms. This is, I think, the NCCN guidelines for immune therapy rechallenge. Here, they're really saying do not rechallenge if you have grade 3, 4 in skin, that grade 4 in the GI colitis, and so forth. And these guidelines are excellent. I thought this was interesting. This was in a paper that I ran across that showed the rate of recurrence according to the initial immune response adverse event. And this showed that about 30% in this particular study of patients had recurrence of the initial event upon rechallenge, and that was higher, higher rechallenge recurrence for colitis, hepatitis, and pneumonitis. I typically do not, for hepatitis, I do not rechallenge, and have done so for colitis and pneumonitis successfully. Moving to second line treatment, what role does the novel alkylating agent lurbinectedin play, or Lurbi as I call it, and what are the data supporting its use? So here's the NCCN guidelines for extensive stage for this, and we talked about the primary therapy. Subsequent, here's the preferred regimens. So if you have a disease-free interval of, I think this has been actually just revised to 6 months, that you should really rechallenge with the original regimen, that platinum-based doublet. Otherwise, if it's less than that, then we really look at lurbinectedin, topotecan. Those are both FDA approved right now. And I really look at clinical trial to try to move the envelope for these patients. So lurbinectedin is a drug that binds in the guanine residue of the minor groove of DNA, and it inhibits transcription and induces DNA double-strand breaks, leading to apoptosis. Here's the data for it, and this led to accelerated FDA approval. This is a relatively small trial, 100 patients, and patients had relapsed after only one prior regimen. This did not include any CNS mets, so we don't know about lurbinectidine really in the brain. And the dose here was 3.2 milligrams per meter squared every 3 weeks IV. And in all patients, all comers, response was 35% overall response rate. And if you were platinum resistant, and here they use a cutoff of 30 days when you recur, that dropped to 22, but still was pretty effective. And if you were sensitive, that actually increased to 45%. And then these patients who do well are doing well. The safety profile, mostly grade 1-2 events, some fatigue, some GI, some diarrhea, and then the grade 3 events included myelosuppression. Here, in general, pretty well tolerated. The FDA approved this in June of 2020 on the basis of the data I just showed you. It's interesting to note that both Pembro and Nivo, which were previously approved with accelerated approval by the FDA, were withdrawn subsequently by the sponsors because of phase 3 data that came after that. Okay, the other FDA approval within the past few years has to do with supportive care, the CDK4/6 inhibitor trilaciclib, which was approved for chemo-induced myelosuppression. So I'm going to spend some time talking about the mechanism of action for this drug. CDKs are multifunctional enzymes that are activated by cyclins, and they regulate cell cycle progression. And chemotherapy drugs target cells at different parts of the cycle. So that's basically what happens with trilaciclib. Is really interesting. It protects hematopoietic progenitor cells by pausing the cell cycle in the G1 phase. So they're protecting those cells from damage by chemotherapy. And this is the article, which is a pooled analysis of 3 randomized phase trials. I'm going to talk about the 3 pooled studies here. It was a total of 123 patients treated with trilaciclib and 119 with placebo. And between the 2 groups, the median overall survival was pretty much the same, the PFS the same, they're comparable. But trilaciclib resulted in decreased myelosuppression and the need for supportive care interventions in this patient population. So fewer patients had grade 3-4 hematologic events. That's 44% versus 77%. And of the patients who continued treatment after cycle 1, 9% of those patients had greater than or equal to 1 chemotherapy dose reduction compared to 30% with placebo. I think the key takeaways from our presentation today are that they're really exciting advances in small cell biology, which will hopefully yield biomarkers to direct treatment. This is not yet prime time, but I think that we're starting to design drug trials to target those therapeutic vulnerabilities in different subtypes of small cell. I think it's really important to consider talking to your IR or interventional pulmonologists about the biopsies for small cell, and just to make sure that you're getting really good needle biopsies, not FNA as previously has been done, because tissue samples are going to be really key for molecular analysis in the future. Platinum etoposide with an immune checkpoint inhibitor is the recommended first-line treatment for extensive stage small cell, and you can use either atezo or durvalumab. And I showed you the updated analysis of both of the Caspian and Empower 133 trials that show continued response benefit to patients. Lurbinectidine is now approved by the FDA for relapsed small cell disease, and trilaciclib is approved by the FDA for chemo-induced myelosuppression. So a lot of advances in the last 5 years compared to the previous 30 years. And now I'm going to turn it over to Henry to talk about the additional takeaways.
So thank you, Dr. Chiang. So the main takeaways for me are that radiotherapy has a crucial role in small cell lung cancer in many contexts, whether it's definitive, consolidative, prophylactic, or palliative. For limited stage small cell lung cancer, we believe that concurrent chemotherapy and radiation, followed by prophylactic cranial irradiation, is still standard of care. But we're also investigating whether or not immunotherapy or the overall omission or modification of PCI are something we should be doing in the future. For extensive stage disease, Concurrent chemotherapy and immunotherapy is standard of care, but PCI and consolidative extracranial radiation are still under investigation in this context, given the advent of using immunotherapy these days in this context. For palliation, stereotactic radiosurgery or whole brain radiation can be used for brain metastases. And we also use low-dose radiation therapy as well for symptomatic thoracic or extrathoracic disease. So thank you very much for your attention today.
And thank you very much as well. I think that one last key takeaway is that it's really important to have a very good multidisciplinary team, as Dr. Park and I work closely together, talk to each other every day, and also involve our surgeons for those early stage patients we didn't talk about specifically today. Thank you so much for your time and attention.
Thank you.
Thank you for listening to the i3 Health podcast. Be sure to subscribe to the podcast so you'll never miss an episode. To claim CME or NCPD credit for this activity, visit i3health.com/ODA-SCLC-treatment. While you're there, you can check out our other free oncology CME and NCPD offerings at i3health.com. Don't forget to follow us on social media for free CME and NCPD, as well as news, exclusive interviews, and more. In addition to our podcast, check out Oncology Data Advisor, where we feature expert perspectives and news stories on the latest in cancer research and treatment, all found at oncdata.com.